I'm honored, although I'm very impressed by all this technology, and I thank Madame Obi and Mr. Beckett for their kindness and for their constant support. I stand here as a tropical ENT surgeon, devoting much of my time to people having head and neck tumors. And due to lack of physicians in my country and plastic surgeons, I belong to a generation which had made some incursion in neighbor specialty like plastic surgery. So I'm very glad to be here to talk about a project of outreach mission for cleft lip surgery. And I'm seeing here on my screen the outline of my topic. After the introduction, I will present some particular aspects of the current situation and talk about the issues that I'm going to develop, why, when, how, and for what results, and pursue with the Miller techniques that I love very much before concluding. Can I see the next slide of introduction, please? So the cleft lip is a universal disease which has different approaches according to the countries. If in northern countries we have very satisfactory results, that is not the case in a southern country. Although in Asia, very nice results and good results have been obtained by our colleagues. But so far, in Africa, under the Saharan desert, we have to make a lot of efforts to have good results. For more than 25 years, I've been promoting head and neck care in remote areas. And I was doing surgery, and this experience has inspired me to think about a project for cleft lip surgery. Next slide. The current situation can be summarized by one single word, which is precariousness or insufficiency. In terms of economical situation, as you may know, most of our citizens in Africa do not earn more than $2 US a day. In terms of number of doctors, in terms of education, medical centers, system of transportation, budget for the Minister of Health, and even for nutrition. So we have 7 items that characterize the present medical and social situation in Africa. Next slide. Now, having said that, I would like to discuss about some issues. Why this project, when and how, and for what results. What result can be obtained through this project that I'm going to develop now. Next slide. Next slide, please. Okay, why do we think about this kind of project? Number one, because of the amount of patients. It has been said that for 1,000 newborn, there was at least one case of cleft lip or cleft palate. In my country, which is probably the case for many African countries, we have 500,000 newborn a year. Through that number, we can estimate that at least 500 patients arrive on the market. And let me tell you that no more than 1/3 of that big number of patients have the benefit of surgery. So through 5 years or 10 years, you can imagine the big number of patients that are on the pipeline waiting for treatment. Number two, we have the basic health staff in our hospitals. Number three, the medical centers exist throughout all our countries. Wherever you go, you will find a medical center. Number four, the budget that is needed for cleft lip surgery is not as high as the budget for, let's say, heart surgery. Number five, the willingness and the enthusiasm can be noted for young generation of surgeons who are eager to help because they consider, like me and you, that it's a question of equity in the ideal of medicine, which is to serve. Next. Next slide, please. Those are considerations about why this project. Now, let us talk about the beginning of the project. When? As soon as possible. Where is the will, there is a way. When exists at least one trained surgeon, ENT surgeon or pediatric surgeon or plastic surgeon, eager to help, then the project could start. When exists at least the basic set of instruments. We don't need many instruments like for lung surgery or orthopedic or heart surgery. The instruments that you can use for appendicit could be easily used for patient having a cleft lip malformation. When the budget is available and the budget is not very high to start this project, when we have a simple place for medical activities. I have good friends of mine who are in Asia who operate on bus, who operate on trains, because they just need a simple medical space to set a table for surgery and to set also instruments for the cleft lip surgery. We need also an agreement with local authorities. If you go at the north or south or east of the country, wherever you go, you need to have the agreement with the local authorities. I'm emphasizing that agreement, and I'm not talking about the agreement of the Minister of Health. If you count on the ministers of health in our country, let me tell you that you will not go far because you will lose time, you won't get satisfaction. So don't count on the ministers of health, but do count on the local authorities and do count on enthusiastic surgeon and medical staff of the places where the mission will be hosted. Of course, we need to have security. You can't go everywhere. You need security because better be safe than sorry. We need security in the place where we are doing surgery, of course. Next slide. Now, here is my proposal. I'm talking about outreach missions with Smile Train, with the cooperation of the West African College of Surgeons, and in cooperation with the medical demography, medical population, medical staff in the countries. We need to start with 3 missions per year. We can start, I think, every 3 months going somewhere to do this kind of mission. We are counting on a team of at least 2 surgeons. If you have 2 surgeons, and even 1, you can start. When I was starting my outreach mission in ENT, I was alone to go everywhere in the country. But if you have 2 surgeons, then it is good, at least 2 or 3. Number 4, the duration of the mission, which is going to start, will be 3 full days, starting in the morning at 8 and ending in the afternoon at 5 or 6 for full days. We need 3 sets of instruments. I'm talking about basic instruments. And again, we don't need a sophisticated set of instruments. We need to work on a main or secondary health center using a suitable surgical technique. Next slide. Now, I would like to say a few words about my preferred techniques, which is the Miller techniques for cleft surgery. This is the most commonly used technique since 1955. It has been described in the United States by a great man called Mr. Miller. It is very easy to understand and to practice. It's almost a passe-partout technique, a very easy one. Few instruments are required, and I'm sure that my friend Sami knows exactly what I'm talking about. The surgeons are not people who want everything to do their work. They can count on the basic instruments. We need few consumables to do this kind of surgery. We need sometimes, if necessary, to use affordable techniques with local anesthesia. I have also a good friend in Manila who do cleft surgery through local anesthesia. So it's a step-by-step techniques. Next slide. This is a picture of the man, Mr. Miller, who described the techniques. He described it a couple of decades ago in Chicago, I think. Next slide. I pretend that Miller techniques use 3 steps in practice. Number 1, identify the landmarks. Number 2, make good incision, accurate incision. Number 3, use suture efficiently. And my 3 S rules are suture, which are simple, solid, and sober. One day, a young surgeon asked me the meaning of the word sober. Sober in French is sobre, which means they're very simple. The suture should be simple, solid, and sober. Next. So in this drawing, around the philtrum, which is here, the cupidon arc, which is here, and the vermilion edge I don't know if you are seeing my mouse. So we have 8 simple landmarks. Next. As I said, you need to do proper incisions. If you want to do a proper incision, then you need a good knife. A knife is not very expensive, but surgeons in Africa know that that is not usually the case. Sometimes you have trouble to have good knives, especially knives coming from countries that I don't want to mention in this presentation. So good incisions will make good flap. You have here on this scheme 3 flaps. The columellar flap, the rotation flap, and the advancement flap. Here you have some landmarks here. So after that, next slide, you will start suture, and this is the final aspect of the surgery. You have a capital Z plasty when you finish your efficient suture. Next slide, please. For what results? Why are we presenting and proposing this project of outreach mission? I like this kind of slide because it summarizes the philosophy of this project. Number 1 is to respond honestly to legitimate demands of the population. Number 2, we should be able to operate at least 5 or 7 cases a day. And if the local situation allows that, we can go to 10 cases a day. But if you want to operate 10 times in a day, then you need a good deal of organization. But I think that with time, we can have the appropriate methods and organization to operate until 10 cases a day. Number 3, the objective is to provide quality care to patients in their land. You don't have to stay in Dakar or in Hadj waiting for people. You go and find the people, the population, and give them good quality care in their land. Number 4, if this is applied, if the project starts, then you will avoid expensive and uncertain travel for people who usually don't have enough money to pay for the transportation. Number 5, you will go and give notoriety or fame to the health center, to the region where the project is hosted. Number 6, teach a man to fish. That is the smile train model. Teach a man to fish. It's better to teach people how to fish than to give him a fish every day. And number 7, respond to smile train philosophy, which is to help and to give smile to people who deserve that, whatever their economical and social situation is. Next slide. Now I'm going to share with you a couple of slides of our own. This young boy has been operated not a long time ago here in Dakar, in the hospital Idriss Apouy. He had left cleft lip. Here, during the anesthesia and the test is set on the table, and here at the end of surgery. Look at the aspect of the vermilion edge. look at the aspect of the cupidon arc and also the final aspect of the suture, realizing a capital Z letter. Next slide. This case is interesting because it's an adult. We do see patients of 30 years or more. Why? Because they are living in remote areas and they did not have chance to be seen by plastic surgeon or dental surgeon or an ENT surgeon. Actually, the first case that I operated long time ago was a man who was already married. And the good thing or the bad thing is that after surgery, his boy did not recognize him and refused it to be taken by him. Next slide. Here we have also a rare case of right cleft lip before surgery and after surgery here. Look at the aspect of the vermilion edge here. Another thing that I like with this method is that it is very good to correct the aspect of the nostril, the lateral side of the nose. We don't have this kind of result with many other techniques, but with Miller, step-by-step technique, using the knife and the scissors, cutting as far as you go. That is the word. You cut as far as you go. And you adjust as much as you need. And doing so, you will have a nice shape of the nose. Next slide. This is a case of a bilateral cleft lip that I have operated in a remote area. I prefer doing step by step, operating one size, and 6 months after or 1 year after, go back and operate the other side. Because I must confess that I'm not a plastic surgeon, I'm not a specialist of cleft lip. I'm a plastic surgeon which I can characterize as an occasional plastic surgeon. That's why I don't take risk and I prefer going step by step, operating one side, and a couple of months after, go back and operate on the other side. Next, please. Next slide. This is me in remote area. I'm going to operate a child who had a bilateral cleft lip. And 6 months before that, I got the opportunity to operate one side. Now I'm going to operate the right side. Next, please. Now let us go to conclusion. This project is coming from my own imagination, but this is not uncommon. If you go in Asia, colleagues do use a system in the project which is similar to the one that I have proposed. So it is not rare, this is not an uncommon project. It is a project which is an efficient project, efficient model, because it is simple, it is sustainable, and it is scalable, which means that you can replicate it in many countries, even in countries where there are not many ENT surgeons or plastic surgeons. Talking about number of plastic surgeons. In my country, you can count them on the digits of one single hand. And I'm sure that in many African countries, you would not find more than 1 or 2 plastic surgeons. Number 3, the success of our ENT outreach mission have inspired me to present such a model for cleft lip surgery. Both missions, both models require comprehension and adhesion, and also commitment. I would like to thank my train for having understood that. Next slide, please. Next slide. I think it is the last slide, which allows me to say thank you to you. Thank you for your kindness. Thank you for your support. Thank you for supporting my English with my Senegalese accent. And I'm sure that I can count on your generosity. Thank you very much.
Hello.
Yes.
Merci, Professeur Diop. C'était vraiment une brillante présentation.
Merci pour vous. Merci, Samy.
Nous sommes vraiment contents de vous entendre parler de cette mission de outreach. Hello, thank you, Professor Diop, for this brilliant presentation. We are so thrilled to hear you talk about outreach. Outreach is something I like very much, and I hope we'll have a lot of very good questions that will come so that we can talk more about it.
Okay, thank you very much. I do have a couple of students in Cameroon, but I'm not sure that they speak English as well as you.
Prof, actually, Cameroon is made up of two parts, the French-speaking part and the English-speaking part. And I came from the English-speaking part, but we studied in French. And so I learned to speak I learned to speak French and to work in English and work in French. That's the blessing of our country, Cameroon.
Congratulations.
Thank you very much. I'm sure there's a couple of questions for you, Prof, on the chat room. And I just want to go through these questions first. Question number one is from Philip, from Dr. Philip. And he says, Prof, do you have a protocol for patients follow-up after the cleft outreach? Est-ce que vous avez un protocole pour le follow-up après votre mission?
Yes, the main part of the thing is surgery by itself. If you follow the principles of this surgery, then you don't need particular follow-up. I mean that every doctor, every nurse can take care of the patient after cleft lip surgery, if that surgery is performed according to the principle. Again, make good incision, have good flap, make good and strong shooters. You don't need a specific kind of follow.
Prof, I think what he's actually asking is that when you leave after the cleft outreach, is there any particular formation or training or those you leave behind who can handle an eventual complication that may come up after this? Because we've had cases in the cleft outreach where the patient came back with an infection or the patient fell and the mouth got broken. How do you leave the team behind to be able to handle that when you are gone? Is there any protocol?
I understand what you mean. And again, I would like to emphasize the notion of respecting the principles. Surgery is a question of principles and respect of principles. If you follow and respect the main steps of the surgery based on the strict and solid shooters, then every doctor behind you can take care of the patient. Of course, if there is some need, we can communicate by the modern means of communications, telephone, WhatsApp, video, etc. And if there is a case of infection, use antibiotics. We don't use systematically antibiotics after this kind of surgery. I don't know.
Okay, thank you very much, Prof. Okay. Thank you, Prof. It's very clear. The second question is from Smile and it goes as such. What would be the ideal minimum medical equipment for a cleft mission? What would be the ideal minimum equipment that Prof will make for a cleft mission?
Well, the answer is very simple. We need this kind of, the kind of instruments that Madame Obi gave me when I went to Abuja a couple of months ago. I have a good bag of instruments, not just for cleft lip, but also for cleft palates, for the outreach mission. But again, we don't need sophisticated instruments for the cleft lip surgery. If you have to do cleft palate surgery, then you need specific instruments. This topic is about cleft lip surgery. And to realize surgery for a child having a cleft lip, you don't need many instruments. Of course, you need a knife, good knife. You need scissors. You have a needle holder. You need also adapted sutures when arrives the time to make sutures. And you need also to be vigilant for respecting the main steps of the surgery.
Okay, thank you, Prof, for that explanation. I think Prof said it. Smile gives us a basic set, and that basic set is enough. And as Prof said, you need at least 3 sets if you're a single surgeon. We make when we go for our teams, we're about 2 to 3 surgeons, so we have about 4 to 5 sets, sometimes even 6 or 7 sets. Okay. Thank you so much, Prof. Now, Dr. Osei. Yeah. Dr. Osei says, I like very much the idea to go to people instead of calling them to come from far. That well done. Thank you so much for this presentation. But well,
thank you very much. Thank you very much for that. I think that we are sharing the same philosophy of giving health to people. You don't have to stay in Abuja or in Yaoundé waiting for people to come and see you. Try to find time to go and see people on their lands and give them the best you can. And if the willingness is there, then you can achieve your goal. Thank you.
Now, Dr. Osei asked the following question, Prof. Do you expect to see parents and patients, or do you usually see parents and patients who refuse to have surgery? In such a case, how do you handle that?
Yes, sometimes people refuse surgery because it's surgery. They refuse to go to hospital because it's hospital. We have now in Cameroon, in Nigeria, in Senegal, cases of people who don't think that the COVID-19 exists. When you ask them to wear masks, they refuse. They don't think that this is a disease which can affect them. Same case for cleft lip. Sometimes the parents refuse surgery. But I know people who just want surgery, treatment for their children, because we are in Africa. We can say many comments about a child who comes in life with a malformation. And Madame Obi knows exactly what I say because she's a woman. When a woman gives birth to a child having malformation of the lip, then many people refuse to see her and say that she is not a good woman and that she should be divorced by her husband. So people who would refuse treatment may be the husbands, maybe men, but not women, of course. Never.
So, Prof, the question is, how do you handle such a situation? Have you had such a situation before? How did you handle it?
Well, we invest on communication. We let them understand that they can have the best for their children. And having that best, the children has enough chance to go to school and have the best education and contribute to the economical development of the country. Children should not be refused such a possibility to have the appropriate education.
Okay, yeah. Prof, thank you. I want to add that I learned something from Maobi, and I want to say chapeau to you, Maobi. You taught me something wonderful. We do a lot of cleft outreaches. We've operated thousands of patients on it. When we are faced with this kind of condition, what we do is that we identify that patient. Normally, maybe a friend or a relative will tell us who the person is. The first day of our cleft mission is very important. We first of all operate clean patients very fast and make sure that by the second day, we send them home. Because people want to see. Once they see, they are convinced. I have about 2 or 3 or 4 cases whereby there were 2 children staying in the house, and one of them came for surgery, the other did come because the parents refused. What we simply did was to operate. We sent a community relay officer to go with that child to that house. The next day, that patient came to the hospital with a parent. So, Prof, try to use this. I learned it from Maobi, you see, and it works very well.
Yeah,
Thank
you are at the same level of comprehension than me. You invest on communication. And communications is to show. Chinese say that it's better to see once than to hear 100 times. And the American people say that seeing is believing. You can show them pictures before and after surgery. And by doing so, you can convince them. Try to show slides, try to show pictures in our office of children before surgery and after surgery. I remember that 25 years ago, I went to the east of my country, a place called Tambacounda. There was no ENT surgeon there. There was no anesthesia doctor, but there was cases of cleft lips. And I made surgery for a child of 18 months. The surgery lasted about 45 minutes. And after that, I took the child on my hands and brought him to the woman, to her mother. When the mother saw the face of her daughter, I just saw that she was going to kiss me. She was really satisfied. She was relieved because she was until then considered as a bad woman. So showing is very important. Showing slides, showing pictures is very important. People believe what they see.
Now, Prof, I have another question from Elise B. It says, what kind of difficulty do you have with young children under local anesthesia? Les enfants sur l'anesthésie locale.
I understand what you say. I must say that I have never experienced doing surgery under local anesthesia in my home, of my own. But I have a good friend in Manila named John Sanchez. John Sanchez is a leader of a foundation called HOW Foundation. He operates using a HOW system, and HOW stands for Hospitals on Wheels. He does surgery in a bus on wheels, and sometimes he uses local anesthesia, but I've never experienced that. I understand that it can be made because I have done thyroidectomies under local anesthesia. And by doing so, I can imagine that it must be possible to use a local anesthesia to do cleft lip surgery. If needed, I will do that. If I'm in a place where there is no anesthetist nurse or anesthetist doctor, but with patients, I will not hesitate to use local anesthesia.
Well, Prof, that would be a wonderful thing to say. What I would like to add there is that we just judge our patients based on age. The younger the child, the more we go towards general anesthesia. The bigger the child, the more we can go to local anesthesia with sedation so they don't disturb us. But it also depends on the cleft pathology, how severe the pathology is. If it's an incomplete lip, a very small incomplete lip, and the child is above 10 or 15, that the child you can be able to manage the child. You can protect such a child and do under local anesthesia with sedation if the child is disturbing. But if not, it will be always best to go under general anesthesia. You're safer, you're safer, you're safer. When you're on
I think you're right. And you are raising a very important issue, which concerns the responsibilities and the responsible of the health system, the health policy in our countries. We should develop education. We should help people to get education. We should train anesthetists, doctors or nurses as much as we need. When I was starting my medical studies, there was just one anesthetist doctor in the main hospital. Now we have dozens of anesthetist doctors because our country has understood, at least the government has understood that it is important to emphasize and to develop education. We should have anesthetist doctor everywhere. If not, we should have anesthetist nurses, at least. It is not a luxury. I think it's legitimate to have doctors and nurses everywhere. And having that, we should not hesitate between local and general anesthesia. Operating under general anesthesia is better, of course. I agree with you.
That's true. I agree. Prof, I have another question here. It says, what auxiliary staff do you need? Do you need some other equipment like suction when you go out on this mission? What auxiliary staff do you need? Do you need equipment such as suctions when you go out on these missions?
Yeah, of course. Having suction facilities is absolutely mandatory. If you do surgery, it is not a very expensive equipment, and it can help for surgery, but it can also for anesthesia. I can't imagine an anesthetist, nurse, or doctor giving general anesthesia without suction tube, suction machine, of course. If you don't have a suction, then don't insist, because it's really basic, natural for people to have suction equipment.
Thank you very much, Prof, for these wonderful answers. Nous sommes vraiment très contents. There is another last question. That question is directed to Dr. Oben. But before I hand over to Smile Train, I have this short observation to do about cleft outreaches. In cleft outreaches, this is what we keep in mind. We want to have safety. We want to have quality. There must be safety at all times. And if you are going to have safety, just as Prof has outlined, you must start preparation from your home. You must leave that mission before ever you leave your home. From one stage to the other, you need security in that place. You need safety. In safety, you make sure you have all the required equipment you need. But to do that, it will be very good you send a team ahead of time to go to the place where you are doing the mission to assess what kind of equipment, what kind of facility, what kind of personnel that you are having in that place. If you don't do that, you will be very, very embarrassed, because you will go there, you will not be able to do much, because you will find yourself very wanting. Now, when that team comes back, you are able to now sit down and plan your mission ahead of time. You will know what you are going to go with and what you are not going to go with. Now, there is a very important question about suction. I have gone on a mission thinking that suction machine was there. When I got there, lo and behold, there was no suction machine. I almost broke my head out. We had to do everything to be able to get a suction machine. You can't do cleft without suction machine. It is impossible, except you're looking for trouble. Don't try it. Make sure if the suction is not there, carry your suction and go along with it. The other aspect I want to talk about this cleft is that you must send a team ahead of time to go for the mobilization and sensitization. Just as Prof said, communication is very important. We do an extensive mobilization, sensitization. We use the TV, we use the local people, we use every person we can find. In fact, what we call the key players on the ground. Not only that, you don't only mobilize the patients, you don't only sensitize the patient, you must make sure you mobilize them, because they must come to the cleft center. Even though you are leaving your center to go to this center, there are still centers that are very, very remote. It means people leaving even to come to where you call your center, it is still very complicated for them. Sometimes we have to go mobilize, send people to pay them transportation, and organize them in little groups. If not, you organize a cleft mission, you go and find 10 patients. You will be confused. You will not know what to do. So you need to go ahead of time, mobilize, use the radio, use the television, use key players on the ground to sensitize these people. And when you sensitize them, it will limit the number of people who will refuse surgery. Then you also facilitate their coming by mobilization. You pay them transportation. You give them possibility of eating. We used to provide them food, though. If you don't provide them food, they will not come. They will tell you, I cannot come to that place. So we give them food, assist them with transportation, bring them, tender them, then you start operating. And as I said, just make sure you operate clean cases on your first day of your surgery. After you've operated those clean cases, send them home. I call it MAOBIS procedure. In 2 days' time, you will see new cases will be arriving. You must always have a contact person. That contact person is the one that has 2 or 3 telephone numbers where patients can call at any time and can get. Let them not call your team. Your team will be busy operating. So they will be calling the person in the local hospital who will be responsible for taking care of them, organizing them, and then you'll be able to reach out for them and operate on them. The other thing is to make sure you leave a good team behind. It is very problematic. If you don't leave a good team behind, you will have a lot of problems. Make sure you have a good team behind to do follow-up and inform you using the social media, whether by telephone or by WhatsApp or whatever means, so that they can get to you and you can tell them what to do, so that you can be able to manage some of these problems. So you see, cleft missions are very good, but they must be well planned. The authorities must be informed, the local authorities must be informed, the hospital must be aware, and the people must know that you've come to help them. So time will not permit me to answer a lot of things, but there's a question on Ketela and local anesthesia. Well, Ketela is a catatonic anesthesia. That's how I call it. It gives a lot of confusion, a lot of trouble. So I'm very careful with Ketela in children so that I don't have a lot of problems. I avoid local anesthesia as much as possible in children. I don't do it. We have a team, and Smile Train has fully equipped us. Thank you, Smile Train. Has fully equipped us with material that we can do general anesthesia. We go prepared for general anesthesia. But in children who are above about 15 years with a cleft which is not very complicated, such as an incomplete cleft, we can do local anesthesia with the cooperation of the child. If the child above between 15 and 20 is not cooperating, we will sedate. But we know the airway must be well protected. That's why I say clefts which are incomplete. If the cleft is complete, general anesthesia straight on. We don't take a risk on that one. I know there's still a lot to talk about cleft outreach. I love cleft outreach. I love it so much. But I'm going to hand over to Maobi. I'm sure she will have, or Smile Train will have one or two things to say. Over to you, Smile Train. Thank you so much, Prof. God bless you, sir. It was a wonderful presentation.
Well, thank you very much. I have listened to those comments very carefully. I was just asking myself if you made the comments for your own, or if you are transmitting comments of another team or another surgeon. What I would like to say is this. Let us be simple if you want to get a result. Let us not be too much demanding if you want to start. If one wants many things to start, then he will wait for a long time before starting. I started alone, and I went alone in remote areas doing ENT surgery. And thanks God, everything went well, because locally I found a good health team, and I found, of course, patients who wanted just to be treated. So we must start, and let us not wait too long before starting. Let us start with what we have, and by doing so, we will have good results. Thank you.
Thank you very much, Professor Malick Diop. This is Philip Shelboala, the Secretary General of the West African College of Surgeons. I was at your place in Dakar, and we really had a nice time.
Thank you. Thank you.
We have really enjoyed your talk today. We've enjoyed your talk, very practical. And from the charts, you have really inspired many of us to consider outreaches. I want to thank you for your time and your contribution. I also want to thank Smile Train for what they do in sustaining these TeleClefts. All our attendees, we appreciate it. Take note that continuing medical education credit points will be awarded. We're at the end, almost at the end of this first series. It will continue tomorrow at the same time. We will soon send you emails about your details so you can put it on your forms. All those who require these points can kindly indicate via the Smile Train email. Thank you for attending. We will continue tomorrow with more interesting topics. Smile Train, over to you.
Thank you very much, General Secretary. Please give my best regard to my friend Clement.
I will do so. Thank you all attendees. We will expect to see you tomorrow at our next session.
Right.
Thank you so much. Thank you, Professor Malick Diop. That was a great presentation. Thank you, Dr. Ben, for wonderful moderation. And just as our SG has said, let's watch out for more interesting times. And please stay tuned and make sure you participate fully to enable you get your CME credits. So see you again next time tomorrow. and have a blessed week ahead. Bye-bye.
Thank you. Thank you, Sami.